Well, what could go wrong if you are a karate kid practicing at 13 years of age and competing at national level? So, here I've got a patient who is a 13-year-old national level karate player, and he experienced some pain in his right sided groin or right hip region some 15 days back, and that he thought that it might get subsided with time, but this did not subside, and now here he is coming to us for an MRI. Here we are able to see that there is some amount of edematous changes on PDFS coronal images, and we see that this is the tendon which is inserting onto the anterior inferior iliac spine. So this is the AIIS, and here the tendon which is attaching here is that of the rectus femoris. So this is the direct head of the rectus femoris which has been avulsed from the anteroinferior iliac spine. So in cases of a young patient, wherever it is below the age of 18, say adults, there is a chance, high level of chance, that the injury would occur at the site of the attachment rather than at the level of the tendon. Because the tendon itself has developed, it would be strong enough. However, the bones have not fused yet, so they are pliable, they are malleable, and they are prone to get injured. So there are various types of avulsion injuries which can occur in our cases during the play, and this occur in and around the hip region. So first thing I would like to point out, what are the things that can go wrong. So here we have got the anterosuperior iliac spine, and at the level of the ASIS we have got the sartorius which is attaching. So this is the sartorius muscle, and as we trace it upwards, it is seen inserting onto the ASIS. Another thing that we will see, and here whatever we have in our case, is that of the rectus femoris. It attaches onto the inferior, that is antero-inferior iliac spine. Now as we move downwards, we have also got the lesser trochanter or the lesser trochanter, wherein there is an insertion of the iliopsoas tendon. And one more thing that we have got is the ischial tuberosity. Here we have got the attachment of the hamstrings, and above and over this, on the anterior aspect, we have got the adductor tendons which originate. So these are the common sites wherein we will see the avulsion type of injuries, especially in young athletes who are prone to have high stress on their body. So coming to our original case, here we see that there is avulsion of the tendon from the bone, and we are seeing some amount of edema and some bony irregularity here. So there is partial avulsion, not the entire tendon has been avulsed or not retracted proximally. So this is a partial avulsion, and we see some amount of hematoma formation as well, some amount of periosteal fluid that we are able to see tracking deep to the iliacus and along the iliac blade. So this injury appears to be some subacute type of injury. Now I would like to point out the anatomy. So the rectus femoris itself has got three heads. One is that of the direct head, the another is an indirect head, and one more head which has recently been described is that of a reflected head. The reflected head goes and attaches onto the capsule, and the indirect head goes and attaches onto the acetabular labrum along with the capsule, and the direct head that we see here, which has partially avulsed, goes and attaches onto the antero-inferior iliac spine. So in our case, we have got partial tear. So based on that, we have got various management strategies. If there is complete avulsion of one or two tendons which has got significant retraction, then definitely we will have to go for surgery, and then there would be suturing of this and reattachment of the tendon. However, when there is partial type of avulsion, the most prominent or the most accepted method is that of a conservative management. The patient is told not to bear weight and to have rest and not to do his regular elite level athletics activities. So the patient is managed conservatively, and usually it takes some 3 weeks to some 6 weeks, between which the patient might get better. One more important thing that I'll have to tell you is, whenever there is conservative management, there is arthritic changes or there is some bony irregularities that develop at the site of the prior injuries, and these are the region which are prone to develop pain on a longer term. So, say the patient would come to you after having suffered this injury and comes to us after, say, 1 or 2 years with chronic type of pain. So, these are the sites which are prone for chronic pain development in this region. And if there is say avulsion of the sartorius like we are seeing here at the anterosuperior iliac spine, there is also a uh, possibility of the lateral femoral cutaneous nerve which lies somewhere in this region getting entrapped within, and this might lead to a pain. So also one more thing that I would like to point out is that it is not always a singular injury that we should look for. We should always look for the entire tendons and all the probable or the possible sites wherein this type of injury can occur. So we should just not have search satisfaction of the search, and we should do a thorough reading of the MRI. And here we have also found that some amount of edema is there within the muscle belly. So there is a low grade strain within the muscle belly. However, there is no significant amount of tear or anything associated with it. Okay, thank you.